Hello, and welcome to another Spotlight the Science, where we meet some of the American Diabetes Association's funded investigators. It's a real privilege. My name is Marlon Pragnell. I'm Vice President of Research and Science at the ADA. It's my great pleasure to introduce to you. Hello.
Hello.
I think we're having an echo there.
Okay. I mean, I can hear you just fine. Yes.
Can you hear me? Okay.
Yeah, no
Okay.
problem.
Okay. So it's my great pleasure to be speaking with Professor Matthew Weber. He's I think I think we're having well, let's hold take a hold for a moment. I think we're having some technical issues here. Abby, can you help us out with echo? Hello?
I'm not having any echo issues on my end. I can hear you just fine. So I don't know if it's some feedback coming on your side or
Yeah,
what, but
I was. Are you not having echo? I was hearing echo on mine.
okay, not a problem. I hear a siren somewhere, but that's about.
I- I'm so, I'm sorry. I'm having a repeat echo in my ear. Okay, we'll try again. Hello?
Look.
I think that fixed it.
Okay, sounds good.
No, it didn't fix it. I'm sorry. I'm just having this repeat echo. Abby, our technical support. Hello, one, two, three.
Abby says, "Try now."
Hello, one, two, three. I'm getting repeat again. Let me disconnect and then reconnect my microphone. Hello. Hey, Abby, I think what I will do is I will disconnect and reconnect again. I'm so sorry for this. Let me try one more time. Sorry. Sorry.
No problem.
Hello?
Hello. Welcome back.
Can everybody hear me? Can you hear me? Awesome. There's no echo. Thanks so much. Thanks for your patience. I had some terrible kind of repeating echo in my ear just now. So let's just get started again. This is a welcome to Spotlight the Science. This is the great time when we actually interview our researchers that are funded by the American Diabetes Association, and it's my great pleasure to actually introduce Dr. Matt Weber. Dr. Weber is Keating Crawford Collegiate Professor of Chemical and Biochemistry and biomedic, biomedical engineering at the University of Notre Dame. He did his PhD in biomedical engineering at Northwestern and at MIT, a postdoc at MIT under professors Bob Langer and Dan Anderson. And he's been doing some amazing work in responsive diabetes, glucose responsive molecules. For example, in diabetes responsive insulin, diabetes responsive glucagon, glucose responsive glucagon. Uh, uh, Dr. Weber, can you just give me an overview of the work you're doing, and let's hear some of the cool stuff that's going on.
Yeah, so happy to be here. My training, like you mentioned, intersects with Bob Langer at MIT, and that was sort of where I got my start in thinking about glucose responsive insulin and glucagon and these kinds of things. I think one of the questions I often get is, do I have some personal connection to the disease of diabetes? And thankfully, I do not. I just really wanted to go to MIT and work with Bob Langer, and he had an opportunity to work on these glucose responsive projects, and I got kind of hooked on the challenge. And so what we're really trying to do is think about molecular scale approaches to the design and formulation of insulin and glucagon therapeutics that have some sort of ability to tune their potency as a function of glucose. And so for insulin, we would want it to become more potent as glucose is higher and less potent as glucose is lower, to sort of match the need, the physiologic need. And for glucagon, we'd want the opposite, right? We'd want a molecule that is kind of inactive or very lightly active at normal blood glucose level, but then maybe turns on as you get to some of these dangerously low hypoglycemic levels. And so our thinking is you could kind of take like a two-prong, almost dual hormone approach with chemistries that can do one thing under certain glucose regimes and chemistries that can do another thing under different glucose regimes, and have both hormones active when they need to be active.
Awesome. So in a sense, what you'd be doing is you'd be taking like an insulin that a person would normally have to inject on a regular basis. You would have it where it would be tuned such that you'd inject it, but then it would only work when you needed it, right? So that when the glucose level changed, the insulin would become active, or the glucagon, for example, if you injected it, it would be inactive. But then if the glucose levels went down, then you would actually have a release of glucagon to kind of restore the levels of glucose, right?
Yeah, I think that's exactly right. I think the insulin, I would say my dream case would be to have an insulin that can match both prandial and basal needs, right? And so you'll see people, type 1s, for instance, that are injecting themselves every morning with Lantus or some long-acting insulin, and then at mealtime are doing a prandial insulin dose, right? And so if you could have an insulin that could kind of do both in one molecule, I think that'd be really awesome. Where you're a once daily, or even better, maybe a once weekly injection, and it has some sort of low level of potency to provide the basal need. And then at meal times or at areas when blood glucose excursions kind of take you upward, the insulin itself gets more potent and provides some corrective action as well in a prandial form. And so I think that would really be the vision for the insulin side of things. The glucagon, I think we're still tuning kind of what the vision looks like. Is it a kind of rescue only case, or is it sort of a yin to the insulin yang, right? And sort of balancing things out and preventing dangerous lows. I think that's a little bit more in its infancy, sort of the vision for the eventual therapeutic there.
Right. So it's almost like, I know we hear a lot about the AID, artificial like automated insulin delivery systems, where you'd have like a device-based approach where a person wear a pump and have a glucose sensor, for example, a technology, and so that would measure the insulin, the glucose levels, and kind of deliver the amount of insulin that's necessary. So this would then be more of a kind of a system that would actually just respond itself, right? So you'd inject the glucose responsive molecule, whether it be the glucose responsive insulin or glucose responsive glucagon, but this would then kind of almost have its own sensor. Is that correct then, or how would that work?
Yeah, so we designed the protein with some sort of built-in ability to sense glucose, and in such a way kind of have autonomous potency control, right? And so you'd think about like, a type 1 diabetic, for instance. I talk to a lot of, parents or a lot of, type 1 diabetics themselves, and they make these decisions of, how many times do I click my insulin pen, and like, did I do it enough? Did I do it not enough? These kinds of things. And you could sort of bake some of that decision making into the technology itself, where if blood glucose is a little higher, your insulin's a little more potent. If blood glucose is a little lower, your insulin's a little less potent, and be able to sort of smooth out some of the I guess the large jumps in typical therapeutic control, and do so in a way where now, some of the decision making is taken out of the hands of the individual and put into the technology they're using.
Right. So then would the person, with obviously this is early stage work and so on, and developing for the future, but How would that work? So a person would then have a say, for example, a glucose responsive glucagon or glucose responsive insulin. They would inject it, but then would they have to inject on a regular basis, like the same every day or every few days, or how would that work? What's the injection like? Is it a I read a bit. You're like working on like hydrogels or gels,
Hmm.
or what would that look like?
Yeah, so I think we have a couple of boundary conditions in our design. And so, I think people are familiar with pen-based injectors, a 30 gauge or a 31 gauge needle, pretty narrow needle diameter, not too large of a penetration depth, not too painful, these kinds of things. I think it'd be really nice to have something that was in that sort of administration device, right? And so you mentioned the gel stuff. Some of the gel stuff, I think, practically speaking, isn't going to be feasible just for high viscosity, and it's not going to be able to be pushed through a needle that size. And so we're working on ways of making these things more injectable, taking some of the concepts from kind of generation one materials design and now engineering in features that allow it to be low viscosity in a pen, but gel in the body, for instance, or these kinds of things. I think just with an eye towards what the actual therapeutic form factor would look like. As far as dosing frequency, in my mind, I think you have daily as an option, and if you can do more than daily, you kind of got to be weekly. I think I just don't think people are very good at remembering, every other day dosing or other things like that. Like people can take it every day, or they can take it every Sunday, or they can take it the first of the month. But I don't think there's like a lot of flexibility for every third day type of profile. And so right now we have a couple technologies that we think we can get 24-hour kind of control, at least in diabetic mice, with multiple challenges throughout the day. um, and then we now, in its infancy right now, but we now have an early scale formulation that actually is doing weekly control, where we can go in and we can do glucose challenges over the course of a week, and the insulin responds. And this is stuff that is it's unpublished, and we're still working on it, but
Mm.
we have some new technologies that we think we can go out to a week. And I think that'd be a kind of a game changer for people if just every Sunday morning, you have your breakfast, you inject your insulin, and then you forget about it till the next Sunday morning, right? I think that'd be a really nice sort of alleviate a lot of that burden
Yeah.
of just thinking about when to dose. So
Yeah. So you mentioned mice. It's obviously all preclinical. So how do you go about designing a molecule then? What do you do, and then how do you test it to kind of see, oh yeah, this is glucose responsive?
yeah, I think that's a really good point. We do a lot of we design molecules with different glucose sensing chemistries. We've been doing development of new glucose sensing chemistries lately. We have a new kind of arm in our group that's making novel glucose sensors, novel glucose binders, and these kinds of things. And that's an area that's a little bit more premature. But we use a lot of old, kind of more established chemistries and integrate those with material platforms. And so we've been doing some of these. I think the aryl boronates, Novo Nordisk has been working on these for 20 years or more, right? I think these are well-known glucose binders. They're just not very good. They're not very specific. They're not very high affinity. And so one of the things we've been doing is re-engineering those to make them, more specific and better affinity. And so that's one way to do it, is just to kind of design the molecular scale glucose binder, and then to design the overall material system such that that glucose binding event has a concomitant change on the material itself. So maybe it makes it swell or makes it dissolve, or do some sort of interesting action that causes the hormone to be accelerated in its release.
Hmm. Hmm. You mentioned like early on, like the great thing we have like two different kinds of insulin, or like, can you add multiple components then, or you have, if you develop like glucose responsive molecule or a drug, is it is it too complex to add multiple components to that, like an insulin or some other hormone or other agent that would then further improve glucose control?
I think we're thinking about that right now. We have some really early efforts in the group. We've done some stuff, even in the past as well, with insulin and pramlintide co-formulations. And so if you look at the data on, co-formulating insulin and amylin analogs like pramlintide, you get better blood glucose control. You have better control over weight and weight gain in type 2 diabetics, and generally better outcomes. They're just kind of a pain because you got to inject them together. You have to inject them separately because they're not formulatable together. And so that's one thing we're thinking about, is strategies to kind of co-formulate and co-deliver adjunctive agents alongside kind of the insulin itself, right? So is that pramlintide? Is it GLP-1s? These kinds of things I think are certainly of interest to us. Right now, we're mostly focused on the insulin piece. We want to get the insulin piece right. I mean, that's the hormone you need. and then the rest are supportive of the insulin piece, I think, and we're kind of try to build those in as we go.
Hmm. So if you were to do something like like as you mentioned, some combination of insulins, so you could envision something where you could have a glucose responsive less tune, so to speak, where you could actually have a single therapy that would actually account for like mealtime insulin versus like, for example, the basal or that you require over a long period of time then, or is that?
Mhm. Yeah. And so the way we think about doing that, I guess, I think there's for a long time there's been this vision in the glucose responsive field that the insulin needs to be like a light switch, right? It's either on or it's off. And from a thermodynamic standpoint, I would argue that that doesn't make a lot of sense. And it turns out in the course of human history, thermodynamics is undefeated. That's a little bit of a chemical engineering joke. But anyway, the way we're thinking about this now is rather than a light switch on off, my insulin is either active or it's not. Maybe it's more like a dimmer switch where
Oh.
the insulin's a little bit active at low glucose and more active at high glucose, and glucose is turning that dial on the insulin and making it more or less active as a function of glucose level. And so that's kind of the way we've been thinking about it. I think initially, the work I was doing at MIT, the work we were doing initially in our group, we were really seeking that light switch, and
Hmm.
that may not be possible. But I do think the dimmer switch, being able to ramp up or ramp down insulin availability as a function of glucose, I think that's definitely possible. So.
Hmm. Hmm. Are there any other? I mean, we're thinking obviously with the we have glucagon. You mentioned insulin. You mentioned pramlintide. Are there any other kind of cool molecules that would be kind of worth kind of tuning to release around with changes in glucose levels? I mean, we're hearing about incretins and all these different things now, and kind of cool other hormones that are involved in glucose control. Are there any other areas that are interesting or on the horizon?
I don't know. I would like to see kind of the interaction of this diabetes metabolic disease space with what we're seeing in sort of the other metabolic diseases like fatty liver and some of these other sorts of things where some of the storage disorders that are arising as a function of kind of glucose imbalance and a lack of homeostasis and in insulin signaling and other sorts of things. I think there's probably some opportunity as people are developing new hormones, new inhibitors to sort of treat some of these other metabolic diseases, where down the road we could integrate glucose responsive control in this space. But I think it's probably a little bit too premature at this point. I think we're still, as a field, still getting a grasp on the origins and the treatment strategies for things like fatty liver and
Mm,
non-alcoholic complications of that as well. So.
yeah, yeah, that'd be interesting. So tell me, how did you get into? I mean, we think about like chemical and biomedical engineering and so on, but what drove you to do diabetes per se? We think of like all these kind of various chemicals and drug release and so on, so many different areas. What drew you to diabetes research?
Yeah, I was trained, I would say, as a molecular engineer in my PhD. It's not a formal discipline, but it's sort of how I was trained, which is to think about problems at a molecular scale and how do you engineer and design molecular systems to overcome those problems. And when I was looking for a postdoc, like I said, I really just wanted to go to work in Bob Langer's lab at MIT, and Bob had just received a grant from the Helmsley Charitable Trust to do this glucose responsive insulin stuff. And Bob said, we got this opening in this grant we just had. Dan Anderson and I just got this grant with Helmsley. You could come and join the team there. And so I was given the role of kind of helping to lead some of those early efforts in the lab. And we developed synthetically modified insulins using molecular design and molecular engineering. Right? How do you make insulin that has a glucose activatable trigger on it? And so that was some of the early work there. We made gels there as well, and we've built on kind of both of those concepts kind of just since then. But ultimately, I just really wanted to go and benefit from the ability to learn under one of the most successful academic entrepreneur chemical engineers probably the most successful in the history of the world, right? I mean, Bob has more patents, more successful companies, more therapeutic products that have reached market than basically anybody in my discipline. And when the opportunity came to work for him, and it came with this expectation that we do something in glucose responsive insulin, it was a no-brainer, right? I was happy to go and tackle a hard problem in Bob's group. And so,
Hmm.
yeah.
So it must have been amazing mentoring by them. I noticed that you're also very passionate about mentoring students and young investigators as well. What advice do you have for like researchers, young researchers that are interested in this area, want to develop their careers? Any thoughts, any advice you have?
I think these are tough problems. I think what we're trying to do is really hard. And I think where I see students struggle is maybe in the resiliency piece. How do you go after something that's actually just super challenging, right? Something like blood glucose control. If you look at it on the grand scheme of things, like relative to other therapeutics, where 100 milligrams per deciliter is good and 180 milligrams per deciliter is too high. Well, that's not even a twofold increase in glucose. And we're trying to design something to be sensitive across that range, right? If I'm doing something like a cancer biomarker, I'm going after something that might be upregulated, 100, 1,000, 10,000 fold over healthy tissue. And I'm using that as my trigger. That's considerably more straightforward, right? I have a benefit of just, a really large delta in the change between healthy and disease.
Right.
Glucose, I have like two, right? I have an order of two, right? I can go from 100 to 180 and that's bad, or I can go from 150 and that's bad, right? And so it's, the range is so tight that, you're really engineering things kind of on a knife's edge. And I think that can be super challenging. And so it's certainly a space that we need some resilience as well. So.
Wow, wow. I can imagine when you say when you contrast that and say this very narrow range, and that you want to tweak the molecule to respond in that narrow. How is that going? How is it must be quite challenging to kind of arrive at kind of molecules that actually have that kind of exquisite level of sensitivity to these different changes.
Yeah, and I think it is, and I'm not certain we're there yet. I think our strategies are getting better, but you play with things like like I've said, the binding equilibrium with glucose, and if you can tune the affinity such that it's right perfectly in that physiologic range, now it goes up or down from there. That binding event changes dramatically, right? But you've got to really tune it. You really have to dial in the chemistries we're using, and so a lot of what we're doing is just exploring new routes to bind in physiologic conditions, to do so in ways that, I go run a marathon and I have high levels of lactic acid in my body, or I have, an artificial sweetener in my body, or I have fructose in my body, and that doesn't turn on my insulin because we don't want the insulin to
Yeah.
turn on around something that's not glucose, right? So making it glucose specific and getting the affinity into the physiologic range really is just, I mean, we're just tuning molecules and trying to really kind of play with the molecular recognition event of glucose.
Yeah. So are you you're focusing mainly on tuning the molecules or you're trying new molecules, or how's that going? So I mean, is it like rational design of existing molecules and changes there, or just kind of almost like screening new entities and so on?
I think we span the full spectrum of that. I mean, we take existing molecules and we tune them, or we make little tweaks to them and kind of try to see if it helps. And so we have an arm of our group that's doing that, and we have a kind of a newer arm of our group that's doing sort of the more, I would call it, less rational design and more just high throughput kind of screening of things. And
Right.
so
Right.
we've got people just making libraries of 100 or 1,000 molecules and screening them and seeing kind of, hey, do any of these have the characteristics of what we're looking for? And
Right.
that, I think, will be that's more of a discovery focused research project. The other ones are more kind of, like I said, tweaking existing things to make it better, doing sort of the kind of fine tuning of existing technology. So.
Mhm. Mm. That's exciting. It seems like we have multiple shots on goal there, where you can actually work with your existing molecules and then also to identify really new, kind of unexpectedly cool molecules that might actually make it even more effective. So this is really fascinating. I think this is early stage research, but my gosh, I mean, something like this, if it could be taken forward and kind of tested in animals and then shown in humans to work and so on, this could be incredibly transformational for
Yeah, I mean,
people
we
with
we
diabetes.
we hope we hope we can have an impact on, either directly or in pushing this field forward, such that someone can have an impact on improving, the quality of life, quantity of life for individuals with diabetes. I think that's really a passion of ours, and I don't have to every time I do an interview like this one or do fundraisers for ADA or JDRF or some of these other ones. I'm often kind of a speaker at these things. The phone in my office is always ringing for the next couple of days with people who want to lend their support or offer help or want to tell me to work faster because their kid's going to college in 4 years and they need a better strategy, or we get all
Yeah.
there's a lot of very invested people in the diabetes space, and we owe it to them to do our best to try to make
Yeah.
make things better. So
Yeah. One thing's clear, this area of research has so much incredible potential. So it's really exciting. I want to thank you for the work you're doing, in this area, and kind of looking forward to the future to see kind of cool things come out of the Weber lab, to see kind of things get to patients and really improve the lives of people with diabetes. So thank you so much for what you do,
I
and thanks
appreciate it,
for giving me an update.
and I appreciate the support of ADA. I think my first big hit on a grant was the 2019 Pathway Accelerator Award, and that really springboarded was a springboard for my group to really get into this area in a meaningful way. And so the ADA I really give a lot of credit to for kind of helping to launch my independent career. So it's been fantastic to partner with the ADA in this work.
Awesome. Yeah, no, we're thrilled to be having just great researchers focusing on research to improve the lives of people with diabetes, to make life easier while people have diabetes, and ultimately to develop a cure. So thank you so much for all you do, and take care and all the best. We look forward to some great research out of the Weber Lab.
Well, thank you, Marlon. I hope we can deliver on that expectation. So
Good, good. Take care. Thanks so much.
thank you.